Welcome to the Deep Dive. Today, we're embarking on a mission, really, to sort of untangle two very challenging and often confused neurodegenerative conditions, Parkinson's disease and dementia with Lewy bodies. This is our deep dive into your sources, trying to understand how clinicians actually navigate this complex landscape. We'll be focusing especially on the critical role of, well, timing and how the symptoms present differently. Now, if you're trying to get your head around the difference between PD and DLB, you first need to grasp what they actually share at the core. Both fall under this umbrella of synucleinopathies, which basically means both conditions come from the same root problem, this abnormal clumping of a protein called alpha-synuclein. These clumps form structures known as Lewy bodies. And this whole process, it leads to nerve cell loss. So because they share this biology, both conditions show up with those core motor symptoms, Parkinsonism, and also some level of cognitive decline.
That's right. And it gets interesting because the term Lewy body dementia, well, people use it quite broadly, but clinically speaking, it actually covers both Parkinson's disease dementia, PDD, and the specific condition we call dementia with Lewy bodies, or DLB. The real challenge for doctors is telling those two apart, because the way we treat them, especially with medications, it can be quite different. So our goal today is really to pin down that key clinical difference, which, as you said, comes down to when the cognitive problems show up relative to the motor ones.
Okay, good. Let's unpack that then. But first, let's establish the physical baseline. Before we even worry about which condition it is, we need to be sure Parkinsonism is actually present. What are the definitive signs we need to see on examination?
Okay, so diagnosing Parkinsonism itself really boils down to confirming three distinct features. The first one, and it's often the most characteristic, is bradykinesia.
Which means slow movement?
Yes, generalized slowness, but we're looking for something quite specific, a sort of progressive decrease in the size or the speed of the movement as it continues. Like, if you ask someone to tap their fingers really fast, the movements might start okay, but they quickly get smaller and slower. They seem to tire out.
Okay. So it's not just being slow overall, it's that inability to maintain the quickness or the amplitude of the movement. Got it. What about the tremor? That's often the first thing people think of with Parkinson's.
Absolutely. The second feature is the rest tremor, and the key word there is rest. This is a tremor that, crucially, tends to disappear, or at least get much better when the person actively uses that limb, like reaching for something. It's often called a pill-rolling tremor. It looks a bit like someone's rolling a small pill between their thumb and index finger. Very subtle sometimes. But if the tremor happens during an action, say when they're lifting a cup, that's not a rest tremor, and that makes us think about other potential causes. And then the third feature is rigidity. Stiffness, basically.
How do you test for that?
We test it passively. So the clinician moves the patient's limb, like their arm or wrist, through its range of motion. If we feel this series of like little catches or stops, almost like a ratchet, we call that cogwheeling or cogwheel rigidity.
Yeah.
It feels like turning a stiff, sort of rusty gear. So if a patient has that bradykinesia, plus at least one of the other two, the rest tremor or the rigidity, then Parkinsonism is confirmed.
Okay, that sets the stage perfectly. Parkinsonism confirmed. Now comes the big question. What's causing it? And this brings us, as you said, to what your sources really highlight as the most critical factor, the timing of the cognitive decline.
Exactly. That timing is the main clinical tool we use to separate PD dementia from DLB. We sort of shift focus from just the physical symptoms and ask, when did the significant cognitive problems, the dementia, actually begin?
Right. And this seems to be the really sharp dividing line that, someone learning this needs to grasp. How does that timeline work in practice?
It's what we call the one-year rule. It's pretty straightforward, actually. If a patient develops clear dementia, significant cognitive impairment more than 1 year after their motor symptoms, like the slowness or tremor, first started, well, then the diagnosis is likely Parkinson's disease, which later developed into dementia. We call that PDD.
Okay, more than a year after motor symptoms equals PDD.
Correct. But if the cognitive symptoms pop up around the same time as the motor symptoms, or, and this is important, if the cognitive problems actually come first, before the major motor signs are obvious, then we diagnose dementia with Lewy bodies, DLB.
That makes the difference much clearer. So PD is primarily a motor disease that might eventually affect cognition later on, whereas DLB, it's almost like a cognitive disease from much earlier. That also happens to bring Parkinsonism along with it, often from the start.
That's a really good way to think about it, yes. And in DLB, those cognitive features, they're not just general dementia. They have distinct characteristics, and they're often much more prominent early on than the motor issues. Your sources actually list specific supportive criteria for diagnosing DLB beyond just cognitive impairment.
What should we look for?
Well, one big one is wide, spontaneous fluctuations in attention and alertness. Caregivers often describe this vividly. They'll say the person has periods where they just zone out, seem really confused or sleepy, and then suddenly they might be almost completely clear-headed for a while before slipping back. It can change hour to hour. Another key feature is recurrent visual hallucinations.
Right, seeing things that aren't there.
Exactly. And unlike, say, auditory hallucinations you might see in other conditions, these in DLB are often very detailed, complex, sometimes surprisingly non-frightening. Patients might report seeing small animals or children or people in the room quite clearly.
Okay, fluctuations and visual hallucinations. And the third major one often comes from the history, doesn't it? Something about sleep.
Yes, REM sleep behavior disorder, or RBD. This is fascinating. Normally, during REM sleep, the dream stage, your muscles are paralyzed, so you don't act out your dreams. In RBD, that paralysis fails. So patients physically act out their dreams. These can be quite vivid, sometimes violent dreams, leading to yelling, flailing, punching, even falling out of bed.
Wow.
And what's really crucial here is that RBD can often start years, even decades, before any motor or significant cognitive symptoms appear. So it might be one of the earliest clues we have about an underlying synucleinopathy developing.
Okay, that distinction based on timing and these supportive features like fluctuations, hallucinations, and RBD is critical. Let's switch gears now and focus hard on management, starting with Parkinson's, because the main treatment involves, well, it's like solving a chemistry puzzle, isn't it? Tackling that blood-brain barrier.
It really is. The cornerstone treatment for PD motor symptoms is the combination of levodopa and carbidopa.
Levodopa is the main player.
Levodopa is the key ingredient, yes. It's a precursor to dopamine. Its real value is that it's one of the few molecules that can actually get across the brain's protective shield, the blood-brain barrier, or BBB. Once it's inside the central nervous system, there's an enzyme called dopa decarboxylase that converts levodopa into dopamine. And that dopamine replaces what's missing due to the disease, helping the motor symptoms.
Sounds straightforward enough. But you mentioned a catch earlier. If the enzyme does its job, what's the problem?
The problem is where that enzyme exists. Dopa decarboxylase isn't just in the brain, it's practically everywhere else in the body too. So if you just give levodopa by itself, a huge amount of it gets converted into dopamine outside the brain, in the periphery.
Before it even gets where it needs to go.
Precisely. This causes side effects throughout the body, like nausea, and it means not enough levodopa actually reaches the brain to be effective. It's like trying to ship something valuable, but most of it gets siphoned off before it reaches the destination.
Okay, so levodopa is the valuable cargo. Then carbidopa must be the security detail.
That's a fantastic analogy. Carbidopa is a dopa decarboxylase inhibitor. It essentially shields the levodopa, preventing that enzyme from converting it outside the central nervous system. And here's the clever part. Carbidopa itself cannot cross the blood-brain barrier. So it does its job in the periphery, protecting the levodopa, but it doesn't interfere with the conversion once the levodopa gets inside the brain. This allows much more levodopa to reach the brain, making the treatment far more effective and reducing those peripheral side effects.
That's a really elegant solution. But we know even with carbidopa, long-term levodopa use isn't simple. There are significant downsides, right? Why do doctors often try to put off starting it, especially in younger patients?
Yes. Despite its effectiveness, we delay it mainly because of two major long-term motor complications that tend to develop over time. The first one is levodopa-induced dyskinesias.
Dyskinesias. Those are the extra involuntary movements?
Exactly. They're these sort of hyperkinetic, often uncomfortable movements, things like writhing, fidgeting, sudden arm flailing, or head bobbing. They're not tremors, they're different. And they tend to get worse the longer someone is on levodopa, and usually with higher doses. They can become quite disabling. The second big issue is motor fluctuations, which patients often call the on-off phenomenon.
Right, I've heard of that.
It's where patients cycle between being on, meaning the medication is working well, and their PD symptoms are relatively controlled and abruptly becoming off. In the off state, the drug effect wears off, sometimes quite suddenly, and their Parkinsonism, the rigidity and slowness, comes back strongly, often right before their next dose is due. It makes predicting function very difficult.
So to try to manage these long-term issues, or at least delay them, clinicians often use other drugs first, especially earlier in the disease. Let's talk about the main alternatives, like dopamine agonists.
Right. Dopamine agonists, drugs like pramipexole or ropinirole, work differently. They bypass levodopa altogether and directly stimulate the dopamine receptors in the brain. They can be quite effective for motor symptoms, particularly early on, and using them might allow us to delay starting levodopa or use lower doses of it initially.
But they have their own set of problems, don't they?
Oh, definitely. The trade-off is significant. Dopamine agonists carry a much higher risk of certain neuropsychiatric side effects. The most concerning are impulse control disorders.
What does that mean, practically?
We're talking about things like developing serious gambling problems, compulsive shopping, binge eating, or hypersexuality. These behaviors can appear out of the blue and can be absolutely devastating to a person's life, their finances, their relationships. Clinicians have to warn patients and families about this risk very explicitly before starting these drugs. They also carry higher risks of hallucinations and excessive daytime sleepiness compared to levodopa.
Wow. Okay, so that's a major consideration. What about the other class sometimes used with levodopa, the COMT inhibitors?
Yes, COMT inhibitors, like entacapone, are always used in combination with levodopa carbidopa. They're never used alone for PD. They work by blocking a different enzyme, COMT, which also breaks down levodopa. So by blocking COMT, they essentially help the levodopa stick around longer. They're particularly useful for patients who are experiencing that wearing off phenomenon, that worsening of symptoms just before the next levodopa dose. Adding a COMT inhibitor can help smooth out the levodopa levels, extending the on time and reducing that off time.
Okay, that really highlights the complexity and the balancing act involved in managing PD. Now let's swing back to DLB, because if managing PD is complex, managing DLB sounds like even more of a tightrope walk, right? The focus shifts much more towards the cognitive and neuropsychiatric stuff.
That's absolutely right. With DLB, you're dealing not just with the dopamine loss causing the motor symptoms, but also a really significant loss of another neurotransmitter, acetylcholine. This cholinergic deficit is thought to be strongly linked to the cognitive impairment, those attention fluctuations, and the visual hallucinations. So management has to address that too. Non-drug approaches like cognitive training are important, but pharmacologically, we often use acetylcholinesterase inhibitors.
Like the drugs used for Alzheimer's disease.
Exactly the same ones, like donepezil or rivastigmine. Sometimes memantine is also used. They aim to boost acetylcholine levels to help with cognition and potentially those fluctuations and hallucinations.
Now, what is the single biggest, most crucial clinical warning that comes again and again in your sources when treating the psychiatric symptoms like hallucinations in people with DLB?
It's the extreme hypersensitivity to antipsychotic medications, especially the older conventional ones. This cannot be overstated.
Why is it so dangerous?
Because many standard antipsychotics work by blocking dopamine receptors. And in someone with DLB who already has depleted dopamine underlying their Parkinsonism, blocking the remaining dopamine activity can be catastrophic. It can cause a severe, sometimes irreversible worsening of their motor symptoms, extreme rigidity, immobility. It can also worsen confusion, sedation, and potentially even trigger a life-threatening reaction called neuroleptic malignant syndrome. Even very low doses can be problematic.
So what's the alternative if someone with DLB has really troubling psychosis?
You have to be incredibly careful. Clinicians must preferentially choose specific, atypical antipsychotics that have very minimal or ideally no effect on dopamine D2 receptors. The ones usually considered are clozapine, quetiapine, or maybe the newer drug, pimavanserin, which works differently altogether. The goal is to treat the psychosis without making the Parkinsonism drastically worse or causing that dangerous rigidity. It's a very fine line to walk.
And does this sensitivity work both ways? If you treat the motor symptoms in DLB with levodopa, can that cause problems with their cognition or psychosis?
Absolutely. It's the other side of the same coin. It's a real double-edged sword. While levodopa carbidopa can be used to treat the motor symptoms in DLB, you have to start at the absolute lowest possible dose and increase it extremely slowly. Why? Because boosting dopamine levels with levodopa can definitely worsen those pre-existing visual hallucinations or other psychotic symptoms. It can also sometimes increase confusion or agitation, so you often find yourself in this difficult clinical bind. Trying to improve movement might worsen psychosis, and treating psychosis might worsen movement. It requires very careful balancing and prioritizing what's most disabling for the patient at that time.
Okay, understood. Now, just to tie up the diagnostic thread for Parkinson's disease specifically, let's quickly cover those final supportive criteria. You've confirmed Parkinsonism, the timing suggests PD. What else helps lock in that diagnosis?
Right. So besides the timing and the core features, a diagnosis of PD is further supported if the patient meets at least two additional criteria. These include things we've touched on. One, having a clear and significant positive response to dopaminergic therapy, like levodopa. If the drugs help the motor symptoms noticeably, that supports PD. Two, the eventual development of those levodopa-induced dyskinesias over time. While a side effect, their appearance is actually characteristic of long-term levodopa use in PD. Three, the confirmed presence of a rest tremor in a limb, as we discussed earlier. And four, finding objective evidence of certain non-motor signs like olfactory loss, a reduced or lost sense of smell, which is very common in PD, or finding cardiac sympathetic denervation on specific types of scans, like an MEG scan.
Got it. And across both conditions, PD and DLB, the sources really seem to stress the importance of supportive care, things beyond just the medications.
Oh, absolutely essential. Supportive care is paramount for both. This means things like counseling for patients and families, robust caregiver education and support, and really importantly, engaging in advanced care planning conversations early on. These are progressive diseases after all. But maybe the most consistent message coming through the research, the key takeaway for listeners here regarding non-drug approaches, is exercise.
Exercise, how does that help?
Regular physical activity might not stop the underlying disease process, but study after study shows it can significantly help maintain quality of life. It seems to benefit both motor function, things like balance and gait, and potentially cognitive function too. It should really be considered a core part of the management plan for anyone with PD or DLB.
That's really valuable advice. Okay, so wrapping things up, what does this all mean for us? We've looked at two conditions, deeply related, sharing core symptoms rooted in that alpha-synuclein protein. The crucial difference really seemed to boil down to that one-year timing rule for dementia onset, alongside those distinctive DLB features like fluctuations and hallucinations, and, critically, those differing sensitivities to medications.
Exactly. And perhaps the final, most practical clinical pearl, something every clinician needs to keep front of mind, is this. Before you even start down the path of diagnosing PD or DLB, you absolutely must rule out medication-induced Parkinsonism.
Ah, drugs causing the symptoms.
Yes. Many common medications, particularly dopamine blockers, think anti-nausea drugs like metoclopramide, or older antipsychotics like haloperidol, and also some drugs that deplete dopamine can cause symptoms that look identical to Parkinsonism. Missing this, failing to check the medication list thoroughly and stop any offending drugs, means you might mistakenly diagnose a progressive neurodegenerative disease when it's actually a potentially reversible drug side effect. It's a critical differential diagnosis.
That is a truly crucial point. What a difference that would make. So the intricate dance between Parkinson's disease and dementia with Lewy bodies is largely choreographed by time, which act, the cognitive decline, or the motor symptoms, take center stage first.
Precisely. And that leaves us with maybe a final thought to ponder, circling back to that shared root cause, the alpha-synuclein protein. We've discussed how both PD and DLB fundamentally involve the misfolding and clumping of this protein into Lewy bodies, yet our current treatments mostly just manage the downstream consequences, replacing lost dopamine or acetylcholine. So the question to think about is, as our understanding of why alpha-synuclein misfolds and accumulates gets deeper, could we eventually develop therapies that target that core protein problem directly? Imagine interventions that could prevent or clear these accumulations, potentially treating the entire spectrum of Lewy body disorders before the irreversible damage occurs, rather than just chasing the symptoms after the fact. Something for us all to watch as the science moves forward.